Good. Now, today's another discussion about a very common bacteria which causes infection in the stomach, which is currently becoming a big problem in terms of cancer of the stomach, stomach and discomfort, parasitic, all those type of conditions about the stomach, which is consuming a lot of money in our economy, in the health economy, which is making so many people not to go to the place of work, which is making people not to be very comfortable in the type of food, so the air price and a modification in terms of diet, and that microorganism is called Helicobacter pylori. So in day-to-day life, we experience this type of discussion that a patient will tell you that I have a h.pyroli or stored, I have a h.pyroli infection, and doctor will tell you that there's h.pyroli infection. Somebody was done an endoscopy and the diagnosis is a H. pylori infection. Again, there is a lot of increase in cases of gastric cancers in our setup, and which is having a lot of trouble. So our discussion today will talk about that Helicobacter pylori infection. Now, you know very well that the human body is made of various systems, like cardiovascular system, which involves the heart and the blood vessels. We have the gastrointestinal system, which is the stomach, the esophagus, the mouth, the rectum, all that. So in the stomach, we have acidic media, which is a very good environment for protein metabolism. And in that stomach, that is where this Helicobacter pylori microorganism dries. It is one of the known bacteria which dries well in acidic media in our stomach. Despite that it's a normal flora, it is also found on the floor, it's found on the soil everywhere. So that is our basis of discussion today. Now, it's one of the most chronic infections in the world, the bacteria, and it consists of human microbe. So it's a gram-negative spirochept type of bacteria, multiple in flagellated, which so that it can move freely, and it produces an enzyme called urease to break down urea, and that one is the biggest reason why we have to study it, because it produces, it breaks down urea to produce ammonia, and ammonia is the one which destroys the the mucosa, then causing a problem in the cells of the stomach. Then it is also it's a microelectric, and it measures a 3 micrometer long with a diameter of about 0.5 micrometer. So that is the diagram of these notorious mycobacteria. Despite that, you have to remember that this bacteria, in some discussion, people call it a protozoa because it has a cell wall. Some people call it a protozoa, some people call it a bacteria. And that one is the reason why the definition of the treatment of this bacteria is approaching with so many drugs. Later on, you'll see them in this discussion. So this slide is showing us various structures of this microorganism. You can see that it has a cell wall. It produces urease, which is an enzyme to break down urea, and then urea is broken down into ammonia and carbon dioxide, and that's the reason why this carbon dioxide is the one makes people to belch and belch. And this belching is the one which causes destruction of the valve, which is called cardiac valve. And then that now brings something called the jet. So it is flagellated so that it can move around. It has a cytoplasmic membrane. So epidemiologically, this microorganism, it affects more than 50% of the world population. And 70 to 80 of these people are in developing countries like Sub-Saharan Africa, where Kenya is. And it's a human genomic sequence study that we got infected 58,000 years back, and more than common in those socioeconomic status, especially people living in Sub-Saharan Africa, people living in informal settlements, like refugees, slums, all those. So human being is the major recipient, and the housing density, crowded condition in the home, number of siblings, sharing beds, and lack of hot water is one of the contributing factor in this case. So that means this microorganism in one way or the other is a wash type of condition related with water, some related with sanitation, some related with hygiene. So you can see that the microorganism distribution worldwide is big. You can see that that is West Africa has 90%, where the southern part of Africa is 80%. Near Kenya, you see that South America is a big number because that is near the tropics. The microorganisms, you can see that the high number of these species are concentrated near the tropics, 90% in North America, 80% again in the far North America. You can see that there is a little number of cases in Asia, a considerable number in Europe, and a few numbers in North America. So you can see that the disease is more concentrated in a tropical region. So there are so many ways of this disease transmission. It's transmitted from person to person, either through gastrointestinal route, through fecal route, or oral route. That is, the concentration of this microorganism is around 100 more than 100 times more than in saliva when it comes to vomiters and the stool. So it is also found in contaminated water. The reason why I say that this disease is also related with water. It's related with sanitation and also hygiene. So we can see that it's a wash type of a disease. So in developing countries, we have seen that in tropics, that's where this disease is very common, and sometimes the cause is not known. For example, in inadequate inspected endoscopic devices, then can be cause of transmission. So the pathogenesis of this microorganism is that the bacteria colonization and the virulence factors is very common. Then it is also determined by the host response to infection, that is the immune response, and also the conditions arising from the infection, because the pathophysiology can follow so many pathways. If this disease is not well controlled, it can cause so many things. Various perspective in this condition, and we will see them later on in this discussion. So the bacterial colonization and the virulence factors and host response can be either gene different in vivo and vitro, and low pH increases mortality, protease, and urease productions. And this one restrict tropsin to gastric mucosa, like in BAB causes Lewis antigen, human leukocyte 2, and then it causes what we call vacuation toxin A, which is produced by h.pyroli. Then also it is causes CAH, which we call cytosine adenine glutamine type of which is associated with the plasmid activation agent, which is one of the mediators which cause this type of problem. Then it's associated to the KGE produces interleukin 8, which is a mediator of acute inflammation. So In this slide, you can see that this microorganism, it has a flagella, and this flagella is to assist this microorganism for the purpose of mobility and also chemotaxins to colonize and the mucosa. So the mobility around the GIT, the chemotaxins, those are the attracts, and the colonizing and the mucosa is one of the key factor of this. Also, it has exotoxins. By evacuating toxins, which is causes gastric mucosa injuries, and you know that these evacuating toxins LA is assisted with the plasminogen activating agent. Then you see that it has lipopolysaccharides, which assist it to adhere to the host cells inflammation, and then it has the outer protein, which also assists to adhere to the host cells. So it also has it produces type 4 secretory systems like pill-like structures for injection of the effectors in the host. So it produces the secretory enzymes like mucin, protease lipase, which their main purpose is to destroy the gastric mucosa so that it can be able to penetrate. So again, effector CAG, etc., it acts as the monitoring, and also it reduces interleukin 8 and also host cell growth and the apoptosis inhibition. So that is the pathophysiology. This is, you can see this also it has as a cells which produces Urease, which the main factor is to break down the urea, and then there is production of carbon dioxide and ammonia, and this ammonia is the one which destroys the mucosa. So you can see that these microorganisms, there are so many pathological agents which are pathogenic, and also you can see that it has its coping capacity, and also it has its protective measures so that it can penetrate, and it also can be protect itself from the gastric acid in the stomach. This is the reason why this microorganism is very virulent and very lethal and very difficult to eradicate it, or rather to treat it in our GIT system. So you can see the gastric lumen, and then you can see the various with these microorganism causes. You can see the cytosine adenine glutamin, that is the CAG-A, which has a plasminogen activating agent. You can see that alternation of the signaling pathways in the main the CAG. What it does, it interferes with the signaling pathways, and then causes cytoexudent, the engagement of the tight junctions. Then you can see the urease, which breaks down urea into ammonia and carbon dioxide, and these ammonia provide a neutral microenvironment favorable for h.pyroli. Now, you can see that it produces bacteria, which is a formation of vacuoles induced apoptosis, disruption of epithelial junctions, and blocks the T cell response. Prostaglandins, lipase, again, reduction of the inflammatory response. Those are the things, the prostaglandin lipase, what it causes in that level. Then you can see that it has adhesins, which makes it be able to adhere to the walls of the GIT. So those are the adaptive mechanism of this microorganism. Now, in this slide, you can see that the various stages of this microorganism in causing the disease. You can see that the gastric fluid, then you can see the gastric mucosa layer where this microorganism it is entering, then it goes and attach itself using the adhesins, then it attaches itself to epithelial cells. In the epithelial cells, it produces urease, and this urease is the one converts urea into carbon dioxide and also the ammonia. And this ammonia is the one which neutralizes the gastric acid, this making that environment very favorable for these microorganisms to thrive there. Then these microorganisms, it attracts other microorganisms and they become many at that place. And this now, the virulence increases and now they produce so many Urease and then they destroy the mucosa is damaged. And that place now, the pepsin androgen is reduced, and this now induces a process of inflammation, which resulted to mucosal cell death and also inflammation because of the pepsin and the gastric acid and the proteins and other effector molecules start now destroying the mucosa cells because of that destruction. Now, in this slide, you can see now a further pathophysiology in various pathways. You can see that h.pyroli, it produces h.pyroli NAP. This NAP provokes the submucosa, then it penetrates the blood vessel. There is activation of the neutrophils. And these neutrophils, now they start migrating to the mucosa surface, now where they go and now start having what we call chromo expansion. They multiply, they induce the process of we call reverse oxidation inhibition, which now causes type 4 secretory system. Type 4 secretory system is the one which assists the DNA to penetrate the epithelial cell. So, so that is how it does. Then you can see that the CAG, the h.pyroli CAG, the CAG cytosine, adenosine, glutamine. Now it it activates interleukin 8, and the interleukin 8 activate neutrophils, and then neutrophils start migrating to the point of inflammation. And then there is also chromo expansion, which results to either reverse oxidation, inhibition, or the neutrophils can attack the epithelial cells, and then there is production of type 4 secretion synthesis. Again, there is release of urease and Urease and protein. This one activate the macrophages, and the macrophages can either cause cytokine-induced changes in the gastric physiology, that one provoking that process of inflammation. Again, these macrophages can induce interleukin 1B, beta, and alpha, and these interleukin can also macrophages can also activate interleukin 12, and then 12 can activate T helper cells, and these T helper cells can activate T helper 2 cells, and then these T helper cells can cause MSC and also expansion of the macrophages, and then the epithelial cells B7-2, and again T helper cells can cause expansion, macronal expansion of interferon Y, that is gamma, which also activate alteration of the mucosa and glycoproteins. And again, you can see that human necrotic factor can activate fast expansion, resulting to a fast expansion is a certain type of protein which interferes with the apoptosis, causing a destruction of the mucosa cell. So you can see that there are so many processes for the purpose of the destruction of the mucosa cell, and that is the epithelial damage of the cell. As a part that and a diagram, there are so many pathophysiology pathways in this pathology. So you can see that the host response in this case now, the host response, it can cause a programmed cell death, that is apoptosis, it can cause vacuolization, and it can cause disruption of tight junctions, it can cause carcinogenic, and that one, all of them, you see them in the clinical manifestation of this disease. So let us see the conditions arising from the infection of this H. pylori. The H. pylori can make so many pathways depending on where it is. For example, it can affect the fundus, the stomach, the body, and the atrium of the heart, and this one can cause acute gastric, acute or chronic gastritis. And this condition is the most common one in most of the populations around. Then it can affect the back, the back of the stomach, and this can cause gastric atrophy, which comprises of the 5% population. Then again, at that point, it can cause gastric ulcers, which comprises 1% of the population. It can cause at atrium, it can cause duodenal ulcers, which comprises of 10%. It can cause gastric ulcers, and also mucosa type of lymphoma, which is comprises of 1% of the population. So in this case, now you can see that the duodenal ulcer is a number increases cancer risk, usually associated with atrial predominant and gastritis, that is the duodenum. Then in the atrium, it predominates gastritis and intact acid excretions, resulting to colonization and larger in atrium and no increase in risk of cancer. So the increase of cancer is in the atrium, but in the stomach, in the atrial part of it does not predominate. And the atrial type of ulcers causes what we call gastric outlet obstruction, because at that point the healing process is due to fibrosis, which interferes with that sphincter outlet there. So the other one is gastric ulcers, which is more often associated with the corpus predominant or Pathogenesis, which increases cancer risk. At that point. So when you do endoscopy, when you're picking a specimen, you have to know where the areas to be concerned in. Then you have the corpus dominant, which is similar to Pathogenesis. And then you have Pathogenesis, which is the even distributed of H. pylori, which can result to atrophy leading to hyperchondrium and increased risk of both adenocarcinoma and MALT type of lymphoma. So in this case, when somebody is doing endoscopy, you have to check on those 5 areas in visualization and also pick a specimen for analysis, because those are the most common areas of pathological changes when somebody has a problem in the stomach associated with H. pylori. Now, as we continue checking on this pathophysiology, you can see a normal gastric mucosa, which is rarely can lead to acute infection, which can, this acute infection can 100% result to chronicity, and this chronicity can result to what? 15% can become atrial predominant gastritis, and 80% can become non-atrophic pharyngitis. Then 5% of these cases can become corpus predominant atrophic gastritis, which is multifocal atrophic gastritis, which comprises of 40%, including the interstitial metaplasia. Out of these 10% develop into gastric ulcers, and also 90% becomes asymptomatic H. pylori infections. And then mucosa-related type of lymphoma is 1%, less than 1%, and this one is very common in anatropic pharyngitis and atrial predominant and gastritis. The 80% can result from interstitial metaplasia, and also 2% can be either dysplasia or gastric ulcers and disease. So there are so many factors players in this case. For example, there is genetic factors like blood group O negative, O positive people are very prone to this type of problem, and the people with autoimmune type of low platelets, also as very common this type of problem, a problem associated with bone marrow, and also the virulence factors leads to increase in 50% of effect of this Helicobacter pylori. So there is various factors which are not gastric associated factors like immunothrombocytopenia, and there is a good level of evidence because of this one, and also patients with iron deficiency anemia, they are prone to developing gastric ulcers associated with Helicobacter pylori. Then there is a minimal information about other causes, which is showing a gap in studies, which requires vigorous studies, clinical trials, and also cohort studies of patients with Leyland's, scleroderma, idiopathic urticaria, and achinoleucodia, and migraine, and GB syndrome to see whether there is a relationship between those type of patients with Helicobacter pylori. Also, there is another relationship like patients who have asthma are prone to have this. There is a relationship between asthma and Helicobacter pylori. Despite there's a scanty data on this. So there is so many areas of study which requires to be studied in terms of a correlation between asthma versus Helicobacter pylori, and these are the conditions. So, diagnosis of Helicobacter pylori is only recommended if a clinician is prepared to treat the patient with a positive test results. So, you have to plan to the end. So, at what time do we do Helicobacter pylori? The standard is when you suspect active gastric duodenal ulcers or a history of peptic ulcer disease without prior treatment of Helicobacter pylori, patient with gastric lymphoma, and the patient who are a follow-up endoscopic dissection of early gastric cancer, or an investigated dyspepsia. And it's very prevalent with the population of more than 20%. So that is the indications, the standard indications of being Helicobacter pylori. Also, other controversial indications are there, like fractional dyspepsia if a population prevalence is less than 20%, and also people who have a chronically in use of proton pump inhibitors, or people who have a chronically using non-steroidal anti-inflammatory drugs, and also people with unexplained iron deficiency anemia or immunothrombocytopenia papilla. First degree relevant relative in gastric cancers also is a controversial. Then a first generation immigrant from regions with high incidences of cancer, gastric cancer is also a controversial indication of doing Helicobacter pylori investigation. So let us see test. Now, an endoscopic test, you can either do a serological test, it can either be quantitative or qualitative by doing a immunoassay. You can do urea blood, you can do two tests of antigens, you can do endoscopic tests like histology, culture, and the PCR assay. So factors that may reduce H. pylori liability is, for example, extensive atrophy of the gastric, or also extensive intestinal metaplasia or MAT lymphoma, use of antibiotics or use of proton pump inhibitors, or use of H2 receptor antagonist like cimetidine, ranitidine, also can cause for you not to be able to rely on the outcome of the results. So when you are doing serological test, either quantitative or quantitative in terms of immunoglobulin G test, there is various advantages and disadvantages. For example, advantages is widely available because it's very common, and then it is less expensive and good non-PV. Then there's disadvantages is there's poor PPV if H. pylori prevalence is low, then not useful after treatment. because the immunoglobulin from still be in the body. Then there is the use of urea blood test as a way of testing it, and the advantages that it identifies active infections, accuracy of not affected by H. pylori, prevalence, and use both before and after treatment. So it's good for follow-up. Disadvantages is this no availability and advancement inconsistent and accuracy affected by proton pump inhibitors, antibiotic use, and a small radiation dose with H14C test um, is another disadvantage. So another test you can do is stool test for antigen test, and this one, the good advantage is that it identifies the active infection accuracy is not affected by H. pylori prevalence and used both before and after treatment because it is a monoclonal type of test. The disadvantages of stool test antigen is that there is fewer data available for polyclonal test and accuracy affected by proton pump and antibiotic use. So when you want to do Urease test, the advantages is that the rapid test result, accurate in patients and not using proton pump or antibiotics, and not added pathological cost. The disadvantage is that it requires you have to do an endoscopy. It is not very comfortable. It has some cost. It has less accurate after treatment or in patients using proton pump inhibitors. So accuracy can be negatively affected by either blood in the stool, in the stomach, or recent use of certain medications such as antibiotic or bismuth containing compound or proton pump inhibitors. So when you have to take an histology for a diagnosis of Helicobacter pylori, there is various advantages, like there is excellent sensitivity and specificity, especially with the special immune stains, provide additional information about the gastric because we have to visualize and give a report and also assess pre-malignant lesions. And the disadvantages that is expensive and because of endoscopy and pathological cost, it's not a very comfortable one. There's some inter-observer variability and accuracy affected by proton pump inhibitors and also antibiotic use. So when you have to do a culture for purpose of diagnosing Helicobacter pylori, is that advantages is that it's 100% in specificity and all allows antibiotic sensitivity testing. Disadvantages, it requires endoscopy, which is not very comfortable, it is expensive. It requires some technical know-how on how to use it and less accurate after treatment or in patients using proton pump inhibitors. So when you have to PCR assay for the diagnosis of Helicobacter pylori, the advantage is that it's a very excellent sensitivity and specificity. It permits determination of antibiotic resistance, and the disadvantages is not widely available, and the technique know-how standardization and also expensive. So now let us look at the treatment of Helicobacter pylori. So the recommended regime usually contains 2 antibiotics and 1 PPI, and the duration ranges from 14 to 10 days, especially now because of this development of drug resistance. So the general complications comprise the usual people to take drugs for all this long and so many drugs because of the pill burden. So the patient should be explained about to accept the minor side effect and regional antibiotic resistance. So the standard regime of treatment is that there is various antibiotics like clarithromycin, and clarithromycin has started developing a very serious problem in terms of resistance. There is amoxicillin, there is metronidazole, tinidazole, tetracycline, there is the levofloxacin and the rifabutin. Currently, also there is azithromycin. Then on the other side, you have omeprazole and someprazole. These are potent inhibitors: pantoprazole, labeplazole, esomeprazole, dexlansoprazole, bismuth, select magnesium, and bismuth and magnesium. Also, there is elaplazole, the 5th generation proton pump inhibitor. So the primary treatment regime for H. pylori infection is that you use a triple therapy, like a proton pump inhibitor, clarithromycin, amoxicillin, of which these drugs has to be taken twice per day for at least 10 to 14 days. You can use macrolide resistant affect the eradication rate, and this regime is not appropriate for region with clarithromycin resistance. And globally, clarithromycin is becoming resistant and expression 70 to 80%. So there is another treatment with a triple therapy with metronidazole, where you give proton pump inhibitors with clarithromycin, and also you can have a metronidazole twice per day, appropriate for penicillin allergic individuals, 70 to 85% of these cases. So there is subsequent therapy, 70 to 95%. They use proton pump inhibitors amoxicillin 5 to 7 days, followed by a proton pump inhibitors, clarithromycin, and metronidazole for 5 to 7 days each twice a day. Then appears to be effective despite clarithromycin resistance. Limited experience to date in United States, either metronidazole or tinidazole may be used as metronidazole. So there is also a quindirect therapy which comprises 70 to 90%, and the proton pump inhibitors that is twice per day plus bismuth, subcycline, and metronidazole, a tetracycline 4 times daily. It is less expensive and complex, and also compliance is an issue. So let us see secondary and risky treatment for Helicobacter pylori. This regime refers to the treatment subject who are failed 2 or more treatment and may consist of alternative primary treatments. So risk treatment is concomitant therapy, where you use proton pump inhibitors plus clarithromycin, amoxicillin, and metronidazole each twice per day. And also you can either metronidazole or tinidazole may be used as metronidazole. The drug is taken 7 to 10 days. Then you can also use a Rifabutin therapy. This one drug you have to be very careful because it's a drug which is preserved for anti-TB treatment, and it's in this case you use proton pump inhibitors plus amoxicillin plus Rifabutin twice per day. The treatment is expensive, adverse hematological events and drug interaction are possible. There is limited data in this type of treatment, and the dose is 14 to 19 days with a success rate of 60 to 80%. So there is also the levofloxacin-based type of therapies. In each regime, levofloxacin is substituted for clarithromycin. There is concern that levofloxacin resistance is increased, and there are limited data about this. So antibiotic resistance significantly affect the success of the triple therapy, but is less important with Bismuth-based regimes. Clarithromycin resistant consist affects the treatment outcome. Metronidazole resistant appears to be more of an in vitro than in vivo phenomenon when metronidazole is used in appropriate regime. There is A2114 gene mutation failure of the triple therapy. So choice of the therapy, previously antibiotic treatments plays a very cool. You have to consider that one. You have to consider the local pattern of antibiotic resistance, drug availability, the cost. Current most referred is 14 days Bismuth containing and non-Bismuth concomitant therapy. When you consider the pharmacological properties of Bismuth, is that Bismuth is a bactericidal. It binds to hasas, inactivation of the pepsin, stimulation of prostaglandins, proliferation of the nicotrins, biosynthesis, binds to the growth factor and stimulates lateral epithelial growth, stimulation of mucus, and inhibition of various enzymes. So that is how this Bismuth works. So the role of probiotics in Helicobacter pylori therapy is that it competes with Helicobacter pylori, lactobacillus retain inhibit Helicobacter in vivo and in vitro, and also this one probiotics decrease diarrhea. So, endoscopic eradication of this Helicobacter pylori is that confirmation of eradication if you have to do post-treatment endoscopy is for the purpose of eradication. You confirm whether the disease has been eradicated or if persistent and recurrent systems, or inpatient advanced malignant conditions like atrophic gastric and intestinal metaplasia, adding gastric ulcers or a greater risk of gastric cancer, cutis, gizzard and lesions, and FND are the cases where you do an endoscopy to follow up. You confirm eradication after 1 month by use urea blood test. You can repeat it 3 months after 1 year, after then 6 months after 2 years, then annually after every 5 years. So, is there a h.pylori vaccine? There is a failed h.pylori vaccine which regulates TLP1 and TLP17 response, and the failed in the third stage in the prophylactic and therapeutic vaccination successful, and it lack potent adjuvants and carriers. And I think that is the head of this discussion. I think you have discussed, you have seen the H. pylori, you have seen the microbiology of it, the structures, the various structures in these microorganisms to prevent it and which make it more that cause diseases. You can see how the body prevents it. You have seen the pathophysiology of various pathways it causes the disease, the way to diagnose it, the treatments, and the various treatment and the rationale of this disease. So with this little knowledge, I think each and every person should be able to tackle this problem and treat this condition called Helicobacter pylori, because it's becoming a nuisance. So, in addition on this one, it is very important for us to have a knowledge in socio and diet advice when it comes to the management of Helicobacter pylori. Thank you very much for listening to this. Thank you.